to
sounds good.
go forward.
Yeah. Hi, everyone. Welcome to the Realising Healthier Pregnancies Research Cluster. My name is Bethan Kingsley. I'm a research associate at WCHRI, and my work is focused on improving health outcomes by working with researchers to translate knowledge, to build kind of meaningful, ethical community relationships, and then to kind of action EDI principles in research practice as well. So I'm the session moderator for the presentations today, and on behalf of WCHRI, I want to say thank you to all of you for coming. And I'm just going to share a couple of slides here. Okay, so I want to begin in a good way by acknowledging that this conversation is taking place on Treaty 6 territory, or at least that's where I am and where WCHRI is situated. So the traditional lands of the Nehiyawak, Dene, Nakota Sioux, Saulteaux, and Blackfoot nations, and the homeland of the Otipemisiwak or Métis. So we honor the profound wisdom, knowledge, and experiences of the Indigenous peoples who've been stewards of this land since time immemorial, and whose teachings continue to illuminate the path forward for our sacred responsibilities as health researchers, now and for generations to come. I'd also like to thank, I don't know if these slides are sharing, so sorry if they're not. I'd also like to thank WCHRI's funders, the Stollery Children's Hospital Foundation and the Alberta Women's Health Foundation for making this research cluster possible. So I will stop sharing. WCHRI is actively seeking to build this cluster. So if you'd like to join or nominate somebody else to join, please reach out to WCHRI. The email address should be in the chat. And Michelle Bayer, who also works at WCHRI, will stay in the session afterwards to answer any questions you might have about participating. So this session will be recorded and posted to the WCHRI website, and then an email will be sent to all of you with the link. And yeah, that should kind of happen within about 24 hours of the presentation. So we look forward to sharing the research with you and encourage questions after each presentation. And then there should be some time at the end also to kind of ask anything left that you have. So on to the presentations. I'd like to introduce you to Matthew Kawana and Miriam Clement. So Dr. Matthew Kawana is a clinical assistant professor at the University of British Columbia. His research program aims to generate high-impact evidence, innovate new models of health delivery, and change public health policy to eliminate the current adverse health gradient experienced by structurally marginalized children and youth due to the social and structural determinants of health. Matthew works in partnership with patients and families, community organizations, and community members to design and implement research projects. And then Miriam Clement is a registered nurse and an assistant professor in the nursing department at the University of Quebec in Outaouais. She has clinical experience in perinatal health and mental health and is currently completing her PhD in public health at the University of Montreal, funded by the Fonds de Recherche en Santé de Quebec. She will be presenting the results of her master's thesis work today. So Matthew, I'm going to invite you to share your slides and start to present.
Great, thank you so much. And thank you for that kind introduction. Is this working for everyone? Okay, wonderful. Well, thank you so much for inviting me to be with you today. Like Bethan mentioned, my name is Matt Caruana, and I'm grateful to be here to share this work. I think really the core of what I try to do is to center the perspectives and experiences of children, youth, and families, and particularly children, youth, and families that are maybe underrepresented in research because of their social context. So I work, like Bethan mentioned, in Vancouver, and specifically I work with a population that's been impacted by substance use. So both parents that use substances in and around pregnancy and early parenting, and then also young people that develop substance use disorders. And I think my goal is always to shine a light on the inherent strengths and resiliency of those folks and not really focus on a deficits-based model about what could be, what's been going wrong, and really try to focus on what's going better and how we can move forward in a good way. thank you for the land acknowledgement for where WCHRI is. I was really lucky to be born and raised here on unceded and stolen territories of the Musqueam, Squamish, and Tsleil-Waututh people. I spent some time during my education out east on traditional Mohawk and Anishinaabe territory, and then I've been back here on these lands since 2014. And I think that it's imperative for us not just to like acknowledge the land that we're living on, but be active in our pursuits towards reconciliation. So speaking truth to the harms that colonial policies, including research policies, have done to Indigenous peoples since contact, and really commit to trying to move forward in a better way through reconciliation. I think it's also a part of my practice now to provide a bit of a positionality statement, because I think recognizing my own positionality is really important in the work that I do. So I'm of mixed European descent. I'm second generation Canadian from 3 of my grandparents, third generation from 1, from everywhere from Malta, Norway, Scotland, and other parts of the UK. It's really a mixed bag. I do identify as a settler. I am extremely privileged. I'm a white cisgendered man in an academic center with a really secure job. But I am also a queer person, and I do bring that experience of my experience as a gay person into my work a lot, because I think it provides a bit of a lens, because I'm used to understanding what it's like to not feel safe in all spaces, not be invited into all spaces. But I recognize that despite that small part of my identity, or that significant part of my identity, overall, I experience tremendous privilege in the way that I operate in our society in Canada. So in terms of what I'm going to try to cover today, I'll start my timer, so I will be 20 minutes, I promise. I'll really briefly share with folks, I think, the benefits of using research co-design and CBPR with families. I know the focus of this cluster is often on pregnancy, and I try to shift that focus towards like families. That's the terminology that our community partners really ask us to focus on, recognizing that it's important to consider the whole dynamic of a family through, of course, pregnancy and childbirth, but also through early parenting, subsequent pregnancies, etc., when trying to do or conduct scholarly work. And then I'll share some key aspects of how to actually do community-based participatory action research in my experience in the community. And then finally provide some examples of successful and in progress community-based participatory action research projects that I'm working on. I wear a few hats. I'm actually do a lot of research with administrative data, and then try to combine that with community-based participatory action work to try to figure out how to best implement the findings or alter the trends that we're seeing in the administrative data. So in terms of why I think co-design in research is important with patients and families, this is a quote that was shared with me some years ago now by one of my best friends and a close colleague, by Dr. Lilla Watson. They're an Indigenous scholar from Australia, and they're very clear that this is not just their own quote, but was developed in concert with many colleagues. But the quote is, "If you have come here to help me, you are wasting your time. But if you have come because your liberation is bound up with mine, then let us work together." And for me, that really like profoundly helps me place my work in context, because I think as a person that, like I mentioned, has so many privileges the way I walk in Canada right now, I really do get stuck in the like, why am I here? Why am I doing this? What is the purpose? What do I have to add in this space? And I think this is the quote that kind of best sums up my relationship to the work that I do and what draws me to the work that I do. I recognize that there is so much more space for us societally to do better in supporting marginalized folks. And I hope to do this work collaboratively. So not be the champion, superstar, lab, big awards person, but to be doing this with folks in the community and uplifting those experiences as best I can. This is some really brand new though literature. This article was just published in JAMA Pediatrics on Monday. And it's a pathway, a roadmap for health equity and population health research proposed by some colleagues from the United States. But the thing that I kind of really found validating about it is that it includes such a wide breadth of different approaches to research. And in the kind of second column around building theory prototype interventions, you really see here a strong emphasis on this type of work, on human-centered design and community-based participatory research as being really essential to advancing health equity. So I think that apart from, scholars like Lilla Watson showing the importance of this work, there's also papers being released right now in JAMA Pediatrics that show how essential it is to be using a multitude of different methodologies, including more community-based methodologies, in order to advance health equity. For me, why I engage in co-design, there's a couple of reasons. So I want to ensure the relevance of the topic that I'm researching to my end users. I want to ensure the relevance of the data that we're generating to end users, because for me, it's the community that is the first recipient of any knowledge mobilization. So I want to make sure they can use the data that we are gathering in a good way, and then worry about all other kind of KM endpoints. I want to ensure that the feasibility of the design to engage with participants and ensure or improve participant safety and inclusion in the research. And then finally, there's some great studies that have shown that co-design and community-based projects are actually a form of integrated knowledge mobilization, because you're actively engaging folks that will use the data through the research program, through the research process. So rather than waiting at the end to share results, folks are included in the knowledge generation and can share that at a community level throughout the project. For me, something that's really important too with trying to close that gap between kind of clinical science and knowledge generation and actual implementation. And like I said, by participating in co-design and involving community in a meaningful way throughout the research process, you're inherently closing that gap, because folks that have the opportunity to use your findings in real time are a part of your team. So they're not waiting for a knowledge mobilization activity. They're there with you the whole time and are able to take that knowledge out into community. And that's something that we've really seen in one of the projects that I'll share with you folks. I also won't acknowledge that it's easy. So doing community work, community-based research in a good way can be extremely complex. It often includes multiple levels of bureaucracy. So, I mean, there's the whole complex health research bureaucracy that many of us are aware of. And then you're adding in often, multiple community partners with their own types of potentially bureaucratic processes. And then also other ways of knowing and thinking. So like indigenized ways of doing work, which can be very different and sometimes stand in contrast to the way that we're used to doing research. And that can make things complicated. There are certainly costs associated with doing this well. I think more and more we're trying to honor that folks with lived experience, we should be compensating their time and their experience as knowledge. And then often folks require additional costs like transportation or childcare in order to participate meaningfully, and that can add up. There's a risk when we do this work of actually inadvertently perpetuating inequity. So we need to really be aware who is and who is not at the table and how representative our population is. I think often as you get, one of my mentors described my work as hyper local. Like I combine this sort of hyper high level and then hyper local work. And I think it's just important to be aware of that, because sometimes community-based work, I believe that there's findings that are generalizable, but some of the work is inherently meant to be for the community. And we need to be aware of that. And then certainly working with community members, there's a high risk of expectation mismatch, mostly related to pace of change. So I think probably all of us know that research can be a slow process. It's not an overnight activity. A project can take many, many years. And oftentimes people that are engaging with us on topics that they're passionate about are looking for change right now. And so I think we need to try to be transparent and try to mitigate some of the harms that could potentially come from that expectation mismatch, and be really clear about our timeline and how we're going to be doing the work and when folks can expect to see results. I want to really quickly provide some, just tips and tricks, I guess, about how to actually conduct community-based participatory action research, because I think it can feel daunting to feel about wading into that space. And this is a kind of collection of thoughts from myself and also my close colleague, Dr. Dania Fast, who's a medical anthropologist with me here at UBC that does a lot of work with young people that use drugs. So in terms of basic principles, I think concepts of time, place, and safety are really critical to be thinking about when engaging with communities. So, for example, how long does it take to build relationships and trust? I've been really lucky that my clinical practice is in the downtown east side. I've been working as a pediatrician in the downtown east side for 6 years. I show up in the same places and the same spaces every week for the past 6 years. And that's gone a really long way for me to be able to build up trusted relationships within the community and meet a wide intersection of folks from Vancouver downtown east side community. And I actually think that amount of time, like in the span of years is probably what's needed to do this work really, really well. I feel like I'm still learning and still deepening those relationships. But just to be aware, it's not something that can be, organically developed overnight. Thinking about how often to meet and where to meet is really important for folks that are participating in community-based research. So you want to strike the right balance of the meetings providing meaning, but not being overly burdensome. And also want to find spaces where people can feel, I guess, a sense of ownership and also safety. So, for example, in the downtown east side, there's a lot of very complex kind of social and structural dynamics where people may or may not feel safe in certain areas. And so we try our best to check in with all of our research participants to make sure that we're meeting in places where everybody feels like they can attend safely. Always being aware of the language that we're using, such as like gender inclusive or person first language, so that people feel safe, seen, and welcomed. And then considering embedding aspects of culture or ceremony that are relevant to the community that you're working with, I think is really vital. And I'll give an example of that later. And or having folks present that can ensure just like the medical safety of participants. So for example, in our work with substance use, we'll make sure, well, I am a clinician, but we'll also make sure that there's a street nurse or somebody with equivalent experience present in case of a kind of medical emergency. It's important once you have a team to work towards building shared principles. So some sort of community agreement or goals. Like I mentioned, there's a big risk of there being a mismatch in terms of expectations from community partners and researchers. One thing that I think we've also become aware of is that both the process and the outcomes are important to people. So I think as researchers, what we mean by that is we can be very process focused. We want to start this work and we want to do it in a good way. But for the folks that we're engaging, they want a new drug policy for youth and they want it yesterday. And so I think it's important not to lose sight of the outcomes while we really think about the process and doing the process as well as possible as well. And I'll say now that I have made so many mistakes and I've found many different ways to apologize. And I think it's always important for us to approach this work with a strong sense of humility because, foibles are inevitable along the way. There's no one size fits all approach and everybody has their own experiences that they're coming to this work with. And I think it's important to acknowledge that as well. The last kind of like really key point for us has been avoiding abrupt ends and being available and open with boundaries. So by that, we mean oftentimes participating in this work can actually develop a lot of meaning for participants. And again, as researchers, we're often like on this very clear cycle, like I have 3 years to do this project and then it's over. If you're not really clear about that, that can sit really poorly with somebody that's dedicated maybe 18 months to working on a project with us. So you really want to find ways to front load when something is ending and or find ways to continue that relationship and continue that capacity building with community partners. And then a lot of the community partners that we work with and that you may work with might not function on kind of the like 9 to 5 schedule that we're used to again as researchers. And I think it's important to try to be available both time-wise and actually like relationally to folks that we're working with in these spaces. I think a huge component of good community work is relationship based. If folks don't trust us as researchers, they're not going to be able to participate to the fullest. And that often requires having less walls up than we're used to having in our research or for my case in my clinical work. And I think that's something that is important to be aware of when kind of wading into community-based research spaces. I'm going to skip through this for time, but we'll be able to show it. There is in the presentation, just to show here, a bit of like a quick budgeting tool if you're doing work and starting to plan a grant that does community work. Kind of like some general ballparks of how to be kind of budgeting for this in your work, depending on the number of meetings or gatherings that you're going to have. So I just wanted to share some examples of what this has actually looked like for us in the community over the past couple of years. One example that's mostly completed and moving on to next steps, and then an offshoot project from that first project that I was a part of. So I've been really lucky over the past number of years to be asked to partner in a community-led research project called Harm Reduction Strategies to help keep families stay together. So one thing we see a lot in the pregnancy and childhood space and family space in downtown Vancouver is separation of children from their parents through the child welfare system. I'll say that our community advocates actually now call the system the family policing system because we know that there is significant surveillance of families from certain backgrounds. And this has led in Canada to Indigenous and Black children being markedly overrepresented in child welfare systems. And I might come to the community saying, I really want to I want to study how to improve early development in children that are maybe exposed to drugs prenatally, which is what I said. And the community said, that's all well and good, but the issue that matters to us right now is how to help support keep families together. And I said, great, I'm happy to support if that is how you kind of see this issue reflected in this the kind of the most significant way, then let's start there and work with that. And the project was actually initiated by community leaders, so a group of elders from the community, as well as another community organization called Rain City Housing that houses a lot of folks in the community. And then we were invited in as research partners to kind of help support the quote unquote research side of things for this otherwise community project. And so the model for this project was using more Indigenous methodology. So I am not Indigenous, and I don't claim to be an expert in Indigenous methodologies, but I have deep respect for Indigenous methods in research and do everything I can as a researcher and as a co-conspirator and ally to kind of amplify and highlight those methodologic approaches. And so for this project, there was a project advisory team consisting again of 6 elders, both Coast Salish elders and elders representing urban Indigenous folks that may be far from their traditional lands. And then several community organization leaders, community members, and then a few of us from kind of the research team. And we developed a project where there was 5 different circles that met. So a circle of mothers, a circle of young mothers, so less than 25 years old, a circle of fathers, a circle of grandparents, and a circle of youth. And we were able to have each of these circles meet once a month over the course of about 14 months. Really mostly to come together and discuss what issues were important to them and coming up for them, and how they were working together with their community to try to support each other when they felt like they were at risk of losing their children to the child welfare system. So like I said, our overall project advisory team met every 3 months, but then the groups met every month. And then what we tried to do to embed knowledge mobilization throughout the project is have our team of project leads and facilitators report back to a wide network of community partner organizations every 1 to 2 months, so that rather than, again, waiting for the end of the project to start sharing back knowledge, we met on a very regular basis to try to provide feedback to community organizations, how they could better support the folks in the community with these experiences of marginalization. We were able to work with elders and also an Indigenous facilitator to make sure that the meetings were centered in appropriate cultural practices. So using talking circles as our approach to kind of knowledge generation, providing tobacco as a gift of thanks, which is a traditional gift in the territory that we work in, as well as having an elder present at every session to debrief if needed. Rather than kind of going the approach of formal transcription, we had a team take notes during the meeting, so more of like a field notes approach, mostly because participants didn't feel comfortable having the meetings recorded. We really wanted to honor sort of those spaces as being sacred for folks. But we were lucky to have facilitators attend that took really great comprehensive notes and then had those notes further transcribed. And then as a research team, we looked at some preliminary potential themes. And then we were able to bring back all of the folks from the participating groups to re-examine the themes that we identified using the medicine wheel. And that was, again, a gift that was offered to us by some of the elders and the Indigenous facilitator that was working on the project with us. And just in sum, we did identify a group of kind of key themes or findings that emerged from this work that are tools that families and community members can use to help, I guess, reduce the risk of family separation, which is, again, has been highlighted by the community that we work with as a really significant harm. So that was things like tapping into culture or Indigenous ways of knowing, having a really clear awareness of the language that we use as providers, and specifically a risk of using biased language. So an example would be we're more likely to even make comments like, that the child appeared well cared for an Indigenous child than we would for a non-Indigenous child. And although that's in many ways a positive thing, what was pointed out to us is that they felt like that was in some ways perpetuating stigmas or stereotypes. There was a emphasis placed on valuing different roles. And what that means is different roles of different caregivers. So I think in our Western worldview of child rearing is often a very nuclear family oriented, but most, I shouldn't say most, I don't want to pan-indigenize, but many Indigenous cultures have a much more holistic view of child rearing, where many different members are considered vital to the well-being of the child. So grandparents, aunts, uncles, neighbors. There's a beautiful image that actually somebody from WCHRI, Grant Bruno, showed at a presentation last week of a turtle, and like that representing the structure of a family. And that's really been echoed in what we found through our work as well. There was a strong emphasis on the importance of supporting connections between families. So recognizing that isolation, so the isolation of one or two parents with their children puts them at increased risk of potential separation, and that importance of providing safe spaces to bring families together to support each other and provide even, informal respite was really, really important. And then finally, the importance of investing in relationships between families and their provider teams so that they really have a good understanding of not maybe only their struggles, but also their strengths, so that in times of crisis, there's an ability to reach out and find other supports rather than only rely on, say, ministry services. One of the big take-home messages that our community members really generated was trying to shift this idea from always being around mandatory reporting to really focusing on mandatory supporting for families. And what could the world look like if we were mandated to support people rather than just report our assumptions about their behavior? And then we wrapped up just in March this project with what we call the witnessing ceremony. So again, this was taken from Coast Salish tradition, but we were able to invite back all the participants of all the circles and do a blanketing ceremony, which again is a ceremony that's very important in many Coast Salish traditions to really honor their participation in the work. And then did a witnessing ceremony where 4 witnesses, I was actually really lucky to be asked to be one of the witnesses, were asked to attend and say some words and carry forward the findings of the project. And then we shared a traditional meal all together. And only then have we now begun to start what we'd kind of consider our typical research knowledge mobilization. So now we're writing the report and writing a manuscript and all those types of things to help get the idea out. We're submitting it to conferences outside of Vancouver. We've submitted to the International Meeting on Indigenous Child Health, for example, to try to really get that message out there, because I think there is some really generalizable findings, but trying to get these themes to the community first is really important. And then I know I'm basically already over time, so I'll just mention that something that was really nice that came out of this project, like I mentioned, is as part of our kind of overall design, we were having these 1 to 2 monthly report backs from the project team to community organizations. And that included the organization that I work for and many other organizations in the downtown east side. And what we kind of realized was that organizations that support families are very disorganized, working in silos, not collaborating, not clear on each other's kind of primary organizational objectives and what they actually can do to support families. And that leads to sometimes like inadvertently, I wouldn't say like a hostile environment, but there can certainly be like finger pointing. This is your responsibility. We can't help with this. When in fact, I think everybody is doing their best and is kind of overwhelmed. So we've started like a new phase of this work called Braiding Wisdoms. This name was brought to us by our Indigenous facilitator, but we're going to be trying to work now at an organizational level to say like, how can we do better to work together? And we were lucky to get some money to work with the Health Design Lab at the Emily Carr University of Art and Design to bring kind of some human-centered design or design thinking to the work. And so this is the model that was shared with us by Emily Carr that we're working with to kind of create hopefully an ecosystem for a viable initiative or change within the community that we're working within. I didn't share the reference for this. I apologize. It's from Medium Magazine. I can add that in before we share the slides. And again, like this is now meant to be a project between the Health Design Lab, community leaders, and some of our research team around the next steps. I should also note, in the spirit of not having harsh, like kind of hard endings, we've applied for separate non-research funding for our 5 circles. So if you remember the actual original project structure of the mothers, young mothers, grandparents, fathers, and youth circles, we've applied for funding for those to continue, not in the auspices of research, but just in terms of like having an ongoing space for community-based support and connection. And we're really hopeful that that fund comes through from a community-based funding opportunity. So that's what I wanted to share with you folks today. I think that we're probably going to move on to Miriam's presentation and then have time for questions at the end. But I really appreciate the opportunity. I'm so passionate about conducting this type of work, and would love to chat with anybody that's interested in doing similar work in this space.
Thanks, Matthew. Yeah, we can take some questions now if you'd like to put your hands up, and I'll try and kind of get to you, in the order that you put your hands up. Or if you feel more comfortable, you can write something in the chat and I can try and interpret what you mean. So just a comment from Stephanie Montesanti. Your work resonates with my work with Indigenous communities in Northern Alberta, so much appreciated for your insights.
I should say too, if anyone's interested in the findings of that project, I'd love to arrange for some of the facilitators and community members to come share. We try not to make it just the academics that share that work. We have some amazing community-based facilitators that share that work and what they found.
You mentioned deficits, trying to avoid deficit research at the beginning of the presentation really briefly. Can you talk about what is deficit-based research and what is the alternative to that?
For sure. So, I mean, I think by that, I mean that oftentimes in our scholarly work, we're focused on trying to identify problems or gaps. That can be really important, especially when it's happening at a systemic level. But I think there's a risk of then turning that lens on the individual or the community level. And I think, so I'm actually sitting today at the Human Early Learning Partnership at UBC, where we do all of the developmental kind of cross-sectional data for British Columbia. And it's something that we think about a lot, like this tension between identifying that a neighborhood or a community has more needs, but then the risk of that finding further pathologizing or stereotyping folks that live in that community. So it's a really kind of fine or delicate balance. And I think more and more, I guess in my work, I'm trying to start, from an assumption that there's a problem. So rather than trying to find the problem, I think if you speak to community members, you can know that a problem is there, and be really solutions oriented and be strengths based. So identifying strengths within a community or within a participant to address that problem, rather than spend a lot of time investing in finding the problem. And that can be tricky because funders like to see clear evidence of a problem. And we're not yet at a point, I don't think, where most research funding organizations will take a statement from an elder necessarily as enough to quantify a problem. I think we're probably getting there, but it's not there right now.
Yeah.
So, and I think for what I'll say too, I think as a physician scientist, I'm doubly conditioned to think that way, because our whole medical training is find a bunch of problems, tell the person what all their problems are, and then fix their problems. And I think in my work now in communities where these issues are deeply structural and there's no quick solutions, it's much more helpful to focus on strengths than to identify every challenge and lay those out, because that just becomes frankly overwhelming and is in my experience less effective.
Mm-hmm. Thank you. Stephanie, you have your hand up.
Sure. Thanks, Matt, for your presentation. I had also provided some of those comments in the chat. One question I had, or comment, and you had touched on implementation science, and that's the space I work in. So a lot of my work is grounded in equity-focused implementation science, in implementing community-based integrated models of care in rural, remote communities that engage First Nation Métis communities up in Northern Alberta. And, an approach that we've taken in designing and implementing community-based integrated care models up north has been to engage and employ the local workforce. So a lot of our projects really involve, training, support of community health workers, or those in that broad umbrella of the term, who are providing reproductive health services, maternal child health services to communities. And there's literature research that supports that that's a critical factor in the success of, any community-based health promotion program that's intended for Indigenous peoples. But at the same and on the other end, we know that there's a lot of challenges in terms of them already being overburdened, and this is an overburdened workforce. And so when we think about successful program implementation, but also acknowledging other important structural and contextual factors that constrain that, what are your insights or thoughts around, really, successful implementation in that context, right? Because successful implementation is about acknowledging the local context, and which are constantly evolving and changing.
For sure. No, those are really good questions. I mean, I think I'd say like the biggest thing that comes to mind is we really do try, like for this project and for the ongoing project, for example, we have two community-based facilitators that are both Indigenous, and they provide so much necessary value to the work that we do. But because of the way their lives are right now, they're living at the downtown east side, parenting multiple children, experiencing these barriers that we face. They might on paper be working 20 hours per week, and some weeks we might get them 2 hours per week, and that has to be okay. I think for us as a community of researchers, so I think a big part is like trying to model this like flexibility, like you kind of mentioned, when folks are facing a lot of these barriers, there's multiple demands on their time. I think I guess one approach that we've taken is trying to be really flexible in how we support people to be a part of our team. And that can impact the timeline and the funds, and like we've been lucky to be funded well enough to be able to kind of like manage that. And to be working with funders that are more like the Vancouver Foundation, for example, that they're much more aware of community-based research and are able to be flexible about that. But it is a challenge. I mean, the other thing that really comes to mind is like I try to work a lot with the Indigenous health team at BC Children's Hospital on a lot of the work we do. We acquired Sherry DeLallo, who was with you folks for a long time, to work with our team recently, but that team is so underfunded as well. Like everything that you've mentioned, like strapped for resources, and it can be a really difficult dance. And I think the last thing I'll say is we are trying, like through this work in community, to identify and build capacity with people that live in the community from a really early age. Like I used to think, to be totally honest, that a lot of the like high school recruitment stuff was like a little bit hokey. But I think what maybe in some settings it still is, but I think that if you can engage and get young people excited about participating in this work from an early age and help them enter the spaces that we're sitting in, which we're only just starting to do, like with my first, like with one summer student this summer, for example, that's where we like hope that we'll have some benefit there. But it is like, I mostly just echo your experience of a lot of these things being really challenging, and thank you for the work that you do, because it's so important to understand. I like to think that we're sort of like, implementation science adjacent, but don't quite, don't even have the bandwidth to think about, to make sure that we're doing this as well as possible, because we're just like trying to get it done,
Okay, I don't think we've got any more questions, but there was just a comment from Mariella. Great talk. I work in Argentina in a mouse model study the effect of malnutrition during perinatal period and brain function. Anytime we want to contact the community, it's very difficult to engage families due to economic instability. Possible to find a place and time for the meetings at the hospital where they assist. Maybe we need to change a strategy for the meetings. So thank you for sharing your experiences. All right, so I think we will transition to Miriam now. Thanks so much, Matt, for your presentation. And Miriam, if you want to share your slides.
Okay, can you see my slide? Whoops. Okay. Hi,
Yeah,
thank you, Matthew, for your good presentation, and thanks everyone for being here. I'm glad to have this opportunity to present my thesis work. Actually, it's funny because Bethan, you said I was going to present my master's work, but it's actually my thesis work. But I'm going to take just a little time to talk about what I did for my thesis, because I think it's related to what the Matthew's presentation, and I'll just take some time to say like what brought me to that thesis project. So yeah, I was a psychiatric nurse, and I was working with young adults at the beginning of schizophrenia. And I did my master project. It was a participatory action research on the coercion used in mental health services, because that was something that was really uncomfortable doing as a nurse, like injecting medication to patients who didn't want to receive it, but it was mandated by the court, or caring for patients that are hospitalized against their will because, you know, mandated by the court. So all these coercive practices was making me uncomfortable, because I could see how much social determinants were affecting the mental health of people. But in the medical system, the only thing that we could do was focused on the medication. So that's why I went into public health, because I wanted to act earlier and, you know, act on the social determinant of mental health instead of being only in the curative and really medicalized system. So that's why I did my PhD in public health. And one of these social determinants is early life experiences. And I wanted also to kind of combine my experiences in mental health and also in perinatal health, which I worked a couple of years before. So my thesis is on the intergenerational transmission of mental health problems. And more specifically, so I'm going to present to you, it's the title is The Combined Roles of Maternal and Paternal Postnatal Depression in the Development of Children Mental Health Symptoms. So, oops, I have a problem with the, okay, I'm sorry. I don't know what's going on. Okay, so just to put it in context, there is a high prevalence of mental health problems among children and adolescents worldwide. It touches from 15 to 25% of the children. And the first year of life is a critical period when the brain is really susceptible to the environmental stressors. And one of these stressors can be a parental postnatal depression. And since it affects from 15 to 20% of women and from 7 to 11% of fathers, it's a good target of intervention to kind of promote promote mental health in children and development. Oh, I don't know why my slides skipped like that. I'm sorry about that. Okay. I'm sorry, I don't know why it does that. And another thing that I wanted to do was to really take a family perspective, because most of the research I've been focusing on maternal depression. And since fathers are more and more involved in, you know, in the child cares in the early life, I wanted to really fill a gap in you know, the effect of the paternal mental health also in child development. And I also noticed that when I was working in perinatal care, that we really focused on the mothers, but we don't really know how to adapt our intervention to fathers. So I really wanted to take this family perspective. And there's also some qualitative research that have reported experiences of the perinatal service by fathers, and they reported that most of them not really appreciate the service offered in perinatal care, or they just find them unhelpful, because it seems like professional lack knowledge of the specific needs of the fathers. Many fathers perceive that professional see them as a source of support of the mother rather than a parent in their own right. Some reported that feeling invisible to caregivers or receiving no support in establishing their relationship with the child. So I wanted to help, you know, some research to be able to maybe develop interventions more specific to father as well. And another reason why it's important to include both parents is that the depressive symptoms tends to manifest in different ways in mothers and fathers. So both parents would have depressed mood, excessive fatigue, decreased interest, or feeling of inefficiency. But for mothers, it's more frequent to have worries about the demand of parenthood, while fathers report more worries about work-life demands. Mothers will experience more often shame, guilt, thoughts of self-mutilation, while father will more often present a blunted effect, indecision, agitation, irritability, or aggressiveness. And mothers report feeling when they're depressed really lonely in their parenthood, while fathers would most likely withdraw from family life when they are depressed. So since the manifestation can change from mothers and fathers when they're depressed, we can think that the influence on the child development will also differ whether it's the mother or it's the father that is depressed. So I'm reporting here. So a large body of research has investigated the associations between maternal depression and children's mental health. So children exposed to maternal depression has around twice more likely to experience internalizing or externalizing symptoms than children unexposed to maternal depression. And there's many studies also reporting that for paternal depression, with maybe a little lower odds ratio, but so children exposed to paternal depression have around 1.5 more chances to have symptoms than children unexposed. But not a lot of studies studied both parents at the same time. So I did a literature review on, the longitudinal studies who measured depressive symptoms in both parents in the same families. So they, compare them. So among these 21 studies, only 7 of them examined the interplay between maternal and paternal depression. 3 of them only examined the role of the family socioeconomic context. 6 of them compared the mechanism for maternal versus paternal depression. And only 2 studies used repeated outcome measures, and only 1 study used a multi-informant rigorous method. Most of them use reports of child mental health reported by the mother only, but that can bring a bias, because when the mother is depressed, she will more likely see many symptoms in her children, which can bias the results. So the general objective of my thesis was to study the combined and distinct roles of maternal and paternal postnatal depression in the development of child mental health problems in various socioeconomic contexts, because I also wanted to have this social economic inequality lens in my work. So in the first article, I tested the moderating effect of the socioeconomic status of the family on the association between parental postnatal depression and child outcomes. In the second article, I looked at the interplay, so the interaction between maternal and paternal symptoms, but also taking account the socioeconomic status of the family. And in the third article, I compared the mechanism that can explain why parental depression is associated with child mental health. And I wanted to compare if these mechanisms change whether it's the mother or the father that is depressed. So I used data from the Quebec longitudinal study on child development, which is a cohort study of 2,120 families with children born in 97-98 in Quebec, excluding the autochthone territories. And I also excluded the single parent families because I really wanted to compare, paternal and maternal depression. So data was collected every 1 or 2 years from the age of 5 months until 7 years. We collected data with interviewing the mothers at baseline and with self-reported questionnaires to the parent, teachers, and the child along the whole period. So the measure, the exposure measure is the parental postnatal depression with at 5 months using the Center for Epidemiologic Studies Depression Scale. The outcome measure is the children internalizing and externalizing symptoms reported by the parents, teachers, and the children themselves at different ages with the social behavior questionnaire. And we also measured the parenting practices, parental marital satisfaction, and family functioning at either 1.5 or 2.5 years old as mediators. And we use many control variables, like the socioeconomic status, child sex, in-utero exposure to smoking or alcohol, parent's lifetime history of depression, parent age at birth, parental antisocial behavior, and family type. So for the data analysis for the two first articles, I used multi-level modeling. For the third article, I used the structural equation modeling to test the association. I used inverse probability weighting to deal with missing data for a family who dropped out, because family who tend to drop out of the study have different socioeconomic socio-demographic characteristic than families who tend to stay in the study. So we applied weighting to avoid bias coming out of this. Also use a multiple imputation and full information maximum likelihood to deal with missing data in the covariates. So here it's just, it's the multi-level model that is represented here. So at the level 1 here in the middle, it's all the observations of the children's mental health. For example, here they were reported from 1.5 years old to 8 years old by the mother. F is the reports from the fathers, T for the teachers, and here from the children. So all these observations were nested by two types of nesting variables. They were nested in the waves of data collection, so like the child ages. And then these were nested in the families at level 3. And the observations were also nested in informants here. So as I said, the robustness, the advantage to use that kind of design is to avoid the same rate or bias and to use a longitudinal approach. So this is kind of one of the strengths of these models. And for the third article, I did kind of the same thing, but using the structural equation framework. So the observations are represented here in the squares, and I created latent variables to represent the symptoms at each age, and then a single latent variable to represent the mean of the symptoms across the whole period. And this variable was inserted here as the outcome in the mediation model to test for the mechanisms that explain the association between parental depression at 5 months and children's mental health from 2.5 to 14 years. So the mediators that we tested are parenting practices, either positive practices, coercive practices, or overprotective practices from the mother or the father, marital satisfaction here, and family functioning. Okay, we wanted to compare if these mechanisms change for maternal versus paternal depression. So in the first article, which is called Parental Postpartum Depression and Children's Social-Emotional Development, the Role of Socioeconomic Inequality. So we found an interaction between the socioeconomic status of the family and the parental mental health in their association with children's mental health symptoms. So here what we can see is the child mental health symptoms, depending on the socioeconomic status. So the slope that we see here represent the socioeconomic inequalities in child mental health. And what we can see is that parental mental health changes this gradient. So when the parent, for example, the father is not depressed, is healthy, the gradient, the socioeconomic gradient is less steep than when the father is depressed. So that's really interesting. So what it says is that parental mental health can in some way maybe reduce these inequalities in children's mental health symptoms. So it's a good target of intervention if you want to reduce these inequalities. And represented another way, here is the association between maternal or paternal depression and children's mental health symptoms. So we can see that this association is stronger in low SES families than in medium or high SES families. And for paternal depression, it's associated with child mental health only in low SES families, but not in medium or high SES families. So the implication, as I said, is that the promotion of parental mental health has the potential to buffer the socioeconomic inequalities in children's mental health, and that screening and interventions promoting postpartum mental health should adopt a proportionate universal approach to prevent maternal depression. So for those who don't know, that this means intervening to the whole population, but with more intensity in low people living in low socioeconomic contexts. And that we maybe should use a targeted approach in low SES families to prevent paternal depression. Now in the second article, I looked at the interplay of maternal and paternal postpartum depressive symptoms with children mental health symptoms. So I tested 4 different theoretical models that could explain the interplay between maternal and paternal depression. So basically, it's how paternal depression can affect the association between maternal depression and children outcomes. So here in the maternal unique model, it would mean that only maternal depression is associated with children symptoms, and paternal depression doesn't change anything, doesn't either increase the association or it's not associated with children's symptoms. In the additive model, both parents would be, depression would be associated with children's symptoms, but they don't interact with each other. So here we can see that even if the father is depressed or not, the strength of the association between maternal depression and children's symptoms is the same. The slope doesn't change. In the synergistic interactive model, the presence of paternal depression would increase the slope, so it would increase the strength of the association between maternal depression and children's symptoms. And in the crossover model, paternal depression would kind of eliminate the association between maternal depression and children's symptoms. So I tested these models and I stratified my analysis in families with low socioeconomic status versus high socioeconomic status, because I already saw that it was a moderator in my first article. So what I found is that in ISCS families, it was the unique maternal effect model. So it kind of confirms the other article, but so in ISCS families, only maternal depression is associated with children's symptoms, but not paternal depression. And in low SES families, it was the synergistic model that fit the data. So the presence of paternal depression increased the association between maternal depression and children internalizing symptoms. And the results were the same for children externalizing symptoms. So what it says is that when children are in families with both parents depressed and in low socioeconomic status, they need way more intervention. So we should really prioritize these children in our intervention to promote their mental health. And finally, in the third article, where I studied the family processes underlying these associations, and I compared there. What I found is that from the association between maternal depression and child outcomes, the mechanisms were the maternal coercive parenting practices, paternal marital satisfaction, and family functioning. Okay, and if we look at, so the total effect was like with a beta of 0.23. So maternal coercive parenting practices explain 22% of the association. Family functioning explained 21% of the association, and paternal marital satisfaction only 4%. And for the association between paternal postnatal depression and child outcomes, paternal coercive parenting practices explain 8%, paternal marital satisfaction explained 22%, and family functioning explained 54%, I'm sorry. So what is interesting in these results is, I would say, the big importance of family functioning for both associations, both for the mother and the father. So what it says is that it's maybe relevant to use a family systemic approach, and when we want to intervene with the presence of mental health problems in families. And that also another point is important is that the parenting practices play a larger role for the association with maternal depression compared to the association with paternal depression, when only 8% explained the association. So it seems like the mechanisms explaining the association for paternal depression are more into like the couple relationship or the whole family relationship, and maybe less in the father-child dyad than for the mothers. So maybe if we want to adapt our intervention, we can, for maternal depression, maybe focus more on enhancing parenting practices, and for paternal depression, focus more on the family functioning and the marital satisfaction. But this is, we have to know that this is a cohort born in 97, 98. There was not paternal paternity leaves at that time. It started in 2006 in Quebec. So these analyses have to be replicated, and maybe in more recent cohort. Maybe it's because at that time child didn't spend a lot of time with fathers. Maybe they spend more time with their father this time. So we have to be cautious about the results. And the other applications is, as I said, the postpartum depression affects children not only through direct interactions, but also through the overall family health, including marital relationship and the broader family environment. So maybe we should target these more higher level factors in our interventions, and that both parents should be involved in the therapeutic process, because there's sort of this spillover, like when the mother is depressed, it affects the father's marital satisfaction, which affects the child. So there's, you know, that each parent's depression has an influence on the other parent too. So both parents should always be included in the interventions. So, as I said, we should repeat our analysis in more recent cohorts. Maybe also these analyses were really on typical biparental families. So I would like in further research to also test these associations in more atypical family structures, like single parents, recomposed, same-sex parents, etc. And I think we should really work on developing and test intervention design to meet the specific need of the fathers. So voila.
Thanks, Miriam. Do you want to stop sharing your slides if you can, and then
Sure.
I can see if anybody has any questions. All right. Feel free to put your hands up, or just turn your video on and I'll see you. Or you can put a question in the chat if you'd rather. Okay, I have a question. So you talked a lot about needing kind of a whole family system approach to interventions. What can realistically be done? So you talked about your background in psychiatry, and I think the approach is very individual. What could, in light of social determinants of health and that kind of thing, what is it that families need, and what could a whole family approach look like?
Well, it already exists, the family system approach. That's something that I teach to nursing students, to maybe just change the way that we approach when we see like a symptom in one person in a family, maybe conceptualize it as a symptom of the whole system instead of something that belongs to the individual. That's really something that I'm trying to teach my future nursing students. So maybe it's just a way to conceptualize, but also maybe more concretely in the system. There's, maybe take habits to systematically involve fathers in all the screening, all the interventions that we do. So yeah, I think the pregnancy is it's an opportunity that we can have, make a first contact with the family. And I mean, I think we should leverage this to recruit, but take a first contact with the fathers and develop a program for them. I'm not sure. I don't have all the answers to that question, but it's something really that I want to investigate to develop. But yeah, the first step is to be aware of like, for example, depression or a mental problem. It doesn't belong to someone, but it's just a reflection of the whole system. So that's the first step. That's where I'm at from now.
Yeah, thank you. Michelle, I think you had a question.
So I don't know, Miriam, how parents in Quebec are asked to complete surveys around their children. So very often here in Alberta, when we're going through a service, let's say at the Stollery, we get one form, and generally speaking, it's the mom that completes the form on the child's behalf. Even if the father's there, the father's not also asked to complete a form. And my partner does not very often share the same opinions as I do with respect to the children. And so I could imagine that if we were to survey both the parents using the same form, there would be some net differences on those forms. Would that type of, systemic approach help in terms of gaining kind of a whole family perspective with the children when they're visited, when they are seen in the hospital setting?
Yeah, well, it's a good example of what I wanted to see, to develop tools that are, I think there should be a form designed for mothers and a form designed for fathers. It's a little bit what they report. They don't want to be only in support of the mother, but they want to be considered in their own, with their own needs. So it's maybe not duplicate things and try to include fathers, but develop things specifically for them. So that would be an example. Yes.
Okay, it doesn't look like we have any other questions, so I'll wrap it up there. So yeah, thank you so much, Miriam, and thank you, Matthew. Matt had to leave kind of halfway through your presentation. He had a family emergency he had to kind of attend to. But yeah, thanks everybody for coming to the cluster presentations. And if you, like I said, if you want to be involved or you have any questions or anything about being involved in the cluster, please stick around. Michelle will stay here, or you can email WCGrants there at ualberta.ca. But yeah, if there's no further questions, we'll wrap it up here. And thanks everybody. Have a good day.
Thank you.
Thank you, Miriam.
Yeah, thanks so much, Miriam.